So we talk about the nasal decongestant today, and the ones we are looking at include pseudoephedrine and phenylephrine. Pseudoephedrine and phenylephrine. So pseudoephedrine is more like an indirect sympathomimetic, and it's like a mixed. So it has the direct and indirect, activity. While we have phenylephrine, which is more like a direct sympathetic adrenergic sympathetic agonist. So, and it typically work on the alpha one receptors. The alpha one receptors. So, what the mechanism by which you use this drug? So, you can use them for nasal decongestion. We can also use them to open, you know, obstructed eustachian tube, maybe from an infection in the middle ear cavity, or maybe from a mass in the nasopharynx, causing occlusion of these eustachian tubes. So, what's the mechanism of their usage? They cause activation of the alpha adrenergic receptors in the nasal mucosa, either directly or indirectly. So, when it's directly, like phenylephrine, it just stimulates that alpha adrenergic receptor. It causes vasoconstriction, so you don't have more blood flow to that area. So, when there's little blood flow in that area, there's little congestion, there's no edema. So, the inflammatory process, subsides. For the indirect one, what they basically do is to act on um the the presynaptic terminals so that they can release norepinephrine and epinephrine. So when they release this catecholamines, they can act on the alpha 1 receptor. So they stimulate the terminals to release norepinephrine and epinephrine that now act on the alpha 1 receptor and bring about the vasoconstriction, limiting blood flow, reducing congestion, and subsiding the inflammatory process. So you can use it to reduce hyperemia because hyperemia is associated with increased blood flow. So when there's increased blood flow to an area, it becomes red. So because of the local vasoconstrictive effect that they exert, you can use it to, minimize hyperemia as well as edema. So just like I've explained, so these, two things, hyperemia and edema, is useful in the presence of being used as nasal decongestant. They can also open obstructive oscillation too because of the similar mechanism, the vasoconstriction, reducing blood flow, reducing the dermatous, swelling of that area, and it eventually open, you know, the oscillation too because the closing is more due to the congestion that is making that place inflamed. So if you can reduce the inflammation by reducing the blood flow, it will open up the oscillation tube and can improve the hearing. Okay, so what are the adverse effects of this drug? Because they are sympathomimetic drugs, they can cause hypertension. They can cause hypertension. But one thing I always want you guys to remember about these particular drugs, especially when you see the question talking about nasal decongestant, is to remember rebound congestion, which is also known as retinitis medicamentosa. So this condition typically occurs when you have used this agent either for a long time or typically for more than 4 to 6 days. Some texts will talk about 5 to 7 days. So, but for the sake of our USMLE, let's just stick to 4 to 6 days. So what happens is when you use this medication for more than 4 to 6 days, it has been observed that the action on the alpha receptors becomes limited. So it becomes reduced. So the activity on the beta receptors, ensues. So that is it. So the beta receptor activity is, what brings about this rebound congestion, in which beta receptor activity brings about vasodilation, and of course, you are going to have more blood cells to die, more blood flow to the area, more congestion, more inflammatory response, and so many things. So when there is more blood flow, you have more of your fibroblasts, more of your lymphocyte recruited to that area, which causes destruction of the epithelial lining of the nasal cavity, the airway that we are talking about, and at the end of the day, there will be increased, activity of the goblet cells that brings about more mucus production, which will worsen the congestion. So some people tend to make mistake, when they observe this condition by further increasing the dose of this agent that they are using. That will even further worsen it. So you don't increase the dose because of this, you know, this problem. So that is why they don't usually prescribe it for a long time. So And even if you are going to be using it, they tend to prescribe maybe once in a day, maybe just once nightly or something. They don't want to use it, for a long time because of this, retinitis pigmentosa effect. It's also shared with tachyphylaxis. So tachyphylaxis is just talking about a rapid decline in the response to the use of a medication over a short time. So you start using a medication today, maybe in 2 or 3 days, maybe in a day or two, you tend to notice a reduction in the response while using the same dose. So that is tachyphylaxis. So there's an explanation for the tachyphylaxis effect when you are using um, these nasal decongestion drugs, particularly when you are using the indirect. It's very common with the use of the indirect agent. So like the pseudoephedrine, it's believed to arise when there's depletion of the neurotransmitters at the synaptic terminals. So with use of this medication, you tend to deplete your norepinephrine at the receptors, and then you don't have anything to stimulate vasoconstriction again. So you observe a less response with the use of the medication. So one thing about tachyphylaxis that's separated from other things like maybe tolerance or something is you have this rapid decline in the response. And with tachyphylaxis, if you increase the dose, you don't get increased response, because the problem here is depletion of the neurotransmitter agent that is driving the response. So it's different from tolerance. In tolerance, it's not usually rapid. It occurs for over like days, to weeks. And if you increase the dose to higher level, you get more response. You get the same response as you were getting before. Let's say that I'm getting response of 30 while using 5 milligram. So when there's tolerance, I need to increase the medication dose to about 10 to still get the response of 30. That is tolerance. But with tachyphylaxis, within 1 or 2 days, you have a reduced response, and it doesn't improve with the increase in the dose. Then the last thing to also remember about them is the fact that they can cross the CNS, the blood-brain barrier, and exert a stimulatory effect on the CNS. So you can have irritability, agitation, and all those things because of the use of um, this medication, particularly pseudoephedrine. So pseudoephedrine can cross the BBB, and they can, drive increased CNS activity or CNS stimulatory effect. So we should not forget that. So don't forget the retinitis pigmentosa and the tachyphylaxis activity that they have. Pulmonary hypertension drugs. So we are just looking at drugs that help us reduce um, the pressure within the pulmonary vasculature. So what do we define pulmonary hypertension as? Does anybody remember what is pulmonary hypertension? Anybody? Dr. Bisola?
Um, about it, I think greater than 35.
What did you say? 35?
Yes.
No, I did not say 35. Oh,
That's
ah,
why is it correct or is not correct?
it's not correct. Oh, it's not correct. Dr. Francois, do you know? Okay. Dr. Zuliat, what about you?
20.
Yes. So pulmonary hypertension is defined as mean pulmonary arterial pressure of more than 20 millimeters of mercury at rest. That is pulmonary hypertension. You guys remember the classes? Do we remember the classes? Class 1 to class 4.
There is 1 to 5. One is like lung issues. That's with the pulmonary artery. 2 is left lung issues. I think
No, no,
3 is
no,
okay.
no.
Left heart, right
Yes.
heart issues. No, it's left heart. It's supposed to go to left.
Yeah.
Left heart issues.
Mhm.
Then I think 3 has to do with systemic diseases. 4 is
No,
idiopathic. Then 5
no.
is
Ah,
multi-disease,
you have, you have,
multifactorial.
you have, you
I've
have, you
scattered
have,
it.
you have scattered it. Mm. One. One is
Oh,
the idiopathic.
Jesus.
One is the idiopathic that we're talking about, the bone morphogenetic protein receptor 1. Bone
Mm.
morphogenetic receptor that helps us control smooth muscle proliferation. So if you have a loss of function mutation of that bone morphogenetic protein receptor 1, you cannot checkmate smooth muscle hypertrophy. So the hypertrophy and you have hypertension. That's one. So one is also, anything that can bring about the endothelial, damage, bringing about increase in expression of endothelin and reduction in the expression of nitric oxide. So things like systemic disease, some infections like HIV, connective tissue disease, someone with uh, you know, a congenital heart disease that is bringing about a left to right shunt and the other things. Then we talked about two being left heart disease. So left heart disease, someone that has a valvular disorder or problem with the left atrium or left ventricle that is causing pooling of blood within the pulmonary vasculature. And we talked about those ones typically having a pulmonary venous hypertension. Then three is when we start talking about the lungs. So hypoxia. So the lungs issue, like we related it to lung parenchyma issue and hypoxia. So lung parenchyma issue, for example, maybe someone that has interstitial lung disease. We also talked about COPD. So someone have a COPD, hyperinflation of the alveoli. The alveoli compresses on the pulmonary capillary that is just beneath it and can explain, you know, the pulmonary hypertension or anything that can cause hypoxia generally, hypoxemia, maybe a shunt or something can also bring about the compensatory pulmonary vasoconstriction that can drive the hypertension. That's three. Then four, we talked about chronic thromboembolism, anything that can affect the surface area of the pulmonary artery. So that can bring about increase in resistance to blood flow and that can explain the hypertension. Then we talked about five as the multi disorders, the multi-systemic. So we talked about hematologic like sickle cell anemia, like thalassemia. We talked about metabolic like gaucher. We talked about systemic like sarcoidosis. So that is the classification. Hmm? Please, did we hear what I said? Or maybe my network was because
We heard you. Thank you.
okay,
Sorry, I couldn't talk earlier because I wasn't around my phone.
okay. So yeah, so one of the ways by which pulmonary hypertension can develop is when you have increased expression of endothelin. So you want to take care of that endothelin. So give an endothelin receptor agonist because we've said two things helps us increase two things control the tone of the pulmonary vasculature. Is that there's increased endothelin that constrict it or there's increased expression of nitric oxide or prostaglandin I2 that help us vasodilate it. So we are now banking on those three mechanisms, you know, to provide solution to the pulmonary hypertension. So endothelin constricted gives something that can oppose endothelin. Endothelin receptor antagonist like bosetan. So they ask this a lot. Bosetan is a very cheap, question. Endothelin receptor antagonist like bosetan, can impede the action of endothelin on the pulmonary vasculature and reduce, the pulmonary vascular resistance because it will not be able to vasoconstrict again. What you guys should just know about is that it is hepatotoxic. So anybody that is placed on this bosetan must have the LFT being continually monitored. The next one is the phosphodiesterase 5 inhibitors. So we've talked about what can help us vasodilate it. Nitric oxide, prostacyclin. Okay, let us work with that nitric oxide. Can we give a drug that can make nitric oxide persist? Okay, why not give phosphodiesterase 5 inhibitors? These ones are um, inhibiting what degrades your cyclic CGMP. So if you prevent degradation of the cyclic CGMP persists and stimulate the release of nitric oxide from the endothelium. So there is increased conversion of nitric oxide from L-arginine. L-arginine is converted to nitric oxide, and nitric oxide exerts a vasodilatory effect. So you can use it to treat pulmonary hypertension. At the same time, it's also used to treat erectile dysfunction. Remember that. So when there is more nitric oxide, there's more vasodilation of the vessels, there's vasodilation of the arteries, more blood flow to your corpus cavernosa or porus spongiosum. At the same time, the veins are also vasodilated. So the veins are relaxed, they can pull in blood, and you can achieve erection. That is it. That is it. You guys remember that when we give something that vasoconstrict the veins, like you give somebody phenylephrine, you can use it to treat priapism. Priapism, because if you give this phenylephrine, it will act on the alpha 1 receptors, they will constrict the arteries. You can now have more blood flow to that corpus spongiosum or cavernosum again. They will also constrict the veins. And when you constrict the veins, you guys remember, you are going to squeeze out blood from that vein. And it will relieve the priapism. That is making of using intracavernosal phenylephrine injection to release, or to relieve priapism. So that is it. You want to avoid using these 5D PD5 inhibitors in someone that has um, someone that is also taking nitroglycerin and nitrates, because you don't want to worsen that vasodilation. You don't want to be to be too much, because it can cause hypotension at the end of the day. So example of this PDE5 inhibitors that we are talking about is sildenafil. So sildenafil, tadalafil, they are PDE5 inhibitors. Then the last one is the prostaglandin. Prostacyclin is also one of the things that can help us vasodilate. So give prostacyclin analogs like iloprost or epoprostenol. So we must familiarize ourselves with these drugs. Epoprostenol and iloprost are, prostacyclin analogs. So they exert, a direct vasodilatory effect on the pulmonary as well as the systemic arterial bed. And they also inhibit platelet aggregation. Don't forget that. They also inhibit platelet aggregation and the vasodilate. So the side effect includes, flushing, jaw pain. Just like bosentan is hepatotoxicity, PDE5 inhibitor is what? Excessive hypotension. Then the prostacyclin analogs is flushing from the vasodilation and jaw pain. Which other drug can cause jaw issues like jaw osteonecrosis? Do you remember?
Bisphosphonates.
Biphosphonate, yeah. So this is just talking about the pathway. So I just feel we need to pick, one or two things here. So endothelin normally is a vasoconstrictor. So it constricts the smooth muscles, that is, it stimulates contraction of the smooth muscle. So it typically works through this, IP3 pathway. So we should not forget that the GQ pathway, the G protein coupled receptor Q pathway, that converts PIP to the action of phospholipase, converting PIP to IP3. So you guys, I know that Dr. Oluwatobi have talked about this before. I've shared a question like that. So PIP2 gets converted to IP3 and DAG. So DAG stays with the receptor. IP3 enters the cell. It stimulates release of calcium, from the endoplasmic reticulum. Calcium becomes released into the cell that stimulate contraction of the smooth muscle. So the calcium work with the DAG, to activate protein C that, drive the remaining process of the smooth muscle contraction. So you want to alter those processes by giving your endothelin receptor antagonist. Remember, if anything contracts smooth muscle, most likely it is through the calcium pathway. And when you are remembering the calcium pathway, you are talking about DAG and IP3, which are product of breakdown of PIP2. Okay, so nitric oxide, we already know nitric oxide, it is CGMP mediated. So CGMP mediated, guanylene cyclase bringing about conversion of GTP to CGMP. So CGMP is available to cause production of nitric oxide that brings about vasodilation. So don't forget nitric oxide, CGMP. Always remember CGMP, nitric oxide. Prostacyclin is very soft. It's very, very soft. That one is the normal adenylate cyclase that brings about production of CAMP. So adenylate cyclase, instead of guanylene cyclase for nitric oxide, it is adenylate cyclase now that act on ATP converting into CAMP. CAMP exerts a relaxatory effect on the smooth muscles. So it relaxes the smooth muscles and brings about vasodilation. Unlike the calcium that contracts it. So CGMP also relaxes, but CGMP is for nitric oxide, not prostaglandin. Okay. Okay, so let's just talk about the asthma and the COPD drugs and we'll round up this topic. So the bronchoconstriction in asthma is mediated by the inflammatory process as well as parasympathetic tone.
Dr. Wallace, sorry, before you leave, the side effect of using PD3 and nitrates, is it hypotension or vasodilation?
Yeah, they will have vasodilation. So their vasodilation will cause the hypotension. Do you get?
So the major direct side effect is still vasodilation, right?
Yeah, but we are looking at it
Okay.
being excessive. We are looking at it when it's too much. See, we said you don't want to take it with other vasodilators like nitroglycerin and nitrates. Do you get it? So these ones exert, high vasodilatory effect on the veins. So you don't want to give something that's already vasodilating the veins another venous vasodilator. You are causing problems. So there's high chance of causing severe hypotension. Do you get it? So it's contraindicated.
Okay.
Yes. So,
Okay.
but the side effect
Thanks.
of sildenafil includes things like sanopia, and other things like that. So they can cause hypotension too, maybe when you use it at very high dose. So
Still vasodilation. Thank you
yeah,
very much. I understand now. Yeah.
all right. So asthma drugs, bronchoconstriction, mediated by inflammatory processes and parasympathetic tone. So when there's increased parasympathetic tone, there's bronchoconstriction. M3. So we are going to talk about it when we get to pharmacology. But just know that parasympathetic stimulation brings about, you know, bronchoconstriction. So that's the mechanism of using methacholine. Methacholine challenge test. You want to provoke. So do we remember what we said about the methacholine challenge test? Anybody?
Yeah, there's an exaggerated response.
Okay.
So, like normal individuals, maybe I can't remember the dose
Yes,
now,
we didn't
but
mention the dose.
normal
We didn't
individuals
mention the
have
dose.
like a response, but in asthmatics, they have like with little dose, they have severe bronchoconstriction
Hmm.
with methacholine. So you use
Yeah,
it to confirm asthma in them, and
yeah,
it's a cholinergic.
hmm yeah. So I agree with you. You've made good justice to it. So that is it. So is it that you want to limit the inflammatory process, or you want to control the parasympathetic tone? You want to reduce the parasympathetic tone, or you want to increase the sympathetic tone? So sympathetic tone, particularly sympathetic tone directed at B2 receptors. So B2 receptors have vasodilatory effect on, I say vasodilatory, broncho-relaxative effect. They relax the smooth muscles of the airway. So what are those drugs that we are talking about? The inhaled beta-2 agonists. So drugs like albuterol, salmeterol, formoterol. So salmeterol and formoterol are long-acting. Albuterol is short-acting. So you can use the short-acting one for relieving acute symptoms. So you need immediate relief, give albuterol. If you want to control it long term, depending on the stage of this asthma, you've classified it, then you can play, if this person needs a long-acting agent, you can place the person on salmeterol or formoterol. So the beta 2, agonists relax the bronchial smooth muscle. What are the side effects? They can cause tremor because, of course, they are adrenergic drugs. They can increase, they are known to, bring about tremor. They can increase the heart rate and cause tachycardia, which will progress to developing an arrhythmia. They can cause palpitation. They can increase the blood pressure. At the same time, they can cause hypokalemia. So remember that beta 2 agonists, can drive in potassium into the cell. So they can cause hypokalemia. Inhaled glucocorticoids, because we've talked about that inflammatory process drives that um, bronchoconstriction. So you want to limit the inflammatory reaction by giving fluticasone or budesonide. So inhaled glucocorticoid or inhaled steroid. What steroid does is to inhibit, they inactivate the NF-κB, so the nuclear factor for KB, kappa, something, something. So this NF-κB is a transition factor that induces production of all the inflammatory cytokines you can think about. Almost all of them, the interleukins, everything is from this NF-κB. So if you give glucocorticoid and you are inhibiting the NF-κB, you cannot produce TNF-alpha and other inflammatory agents. So you are stopping inflammatory process entirely. And you remember that in addition to this, it also exerts individual effect on, the leukocytes. So it causes neutrophilia, but it causes lymphopenia as well as what? Eosinopenia. So but it increases, the level of white neutrophils in the blood because you cannot sequester them from the blood to the inflammatory site. So it's confined to the vascular compartment. And if you do the neutrophil count, you are going to see elevated. So it doesn't cause neutropenia, but it causes neutrophilia. So it's usually the first line for chronic asthma. You want to give your ICS, combining with your beta 2 agonist for someone that has a chronic asthma. But you always want to ensure that you are using a spacer device. So if you use a spacer device, you are increasing the concentration of the steroid that gets into the airway directly, so that you can reduce the occurrence of developing oral throat. So people that have corticosteroids exposed to their throat, the inflammatory um, the immunity at that area reduces because you have less white blood cells there, and you can have overgrowth of some of those commensals that are there, like the candida and like, so the person can develop oral thrush. So one of the ways, if someone is an adult and the person cannot use a spacer, is to ensure that you rinse the mouth after you use of your inhaled corticosteroid to limit development of the oral candidiasis. So, okay, because of the fact that we know that glucoconstriction is driven by the parasympathetic tone. So you can give muscarinic antagonists like tiotropium or ipratropium. So tiotropium is long-acting form, ipratropium is short-acting. They competitively block the M3, the muscarinic receptors, preventing bronchoconstriction. You can also use them for COPD, your muscarinic antagonist. So that is that. Then anti-leukotriene. So we have to pay attention to all these ones very well. They test it. All these anti-leukotriene. So drugs like montelukast, zifalucast, they are anti-leukotrienes because they block the leukotriene receptor. So there are 16 leukotriene receptor blocker. 16 leukotriene, like when you are talking about leukotriene C, D, E particularly. So those are the 16 leukotrienes, and they mediate this inflammatory process in people with exercise-induced asthma and aspirin-induced asthma, especially those this aspirin-induced asthma, because we remember in someone that has aspirin-induced asthma, you're having utilization of aspirin that is blocking the cyclooxygenase enzyme, reducing the production of prostaglandin. Because of that, the activity of your lipooxygenase enzyme becomes unopposed. So it increases its activity and it produces the leukotrienes, which can drive the inflammatory process. So exercise induced form of asthma also is mediated by increased activity of your leukotriene. So because of that, they tend to use leukotriene receptor antagonists like montelukast and zivalucast to treat those kind of asthma. So you should not forget the SAMSTAT triad for aspirin-induced asthma. So there's aspirin hypersensitivity, there's nasal polyps, and there's asthma. So SAMSTAT triad. So what do you want to give that person, anti-leukotrienes agent? So another form of this anti-leukotrienes is what? Xylitol. But Xylitol is not a leukotriene receptor blocker. It's a drug that even inhibits the formation of those leukotrienes. So it is after they are formed that they are binding to their receptor. So why not just prevent their formation? So 5-lipo-oxygenase inhibitor, which is an enzyme that is increased in people with aspirin-induced asthma. So block that enzyme, reduce its activity, so that it cannot convert your arachidonic acid to leukotrienes. But look, Xylitol is hepatotoxic. It is hepatotoxic. Okay, another class of agent that can be used is the anti-IgE monoclonal therapy, omalizumab, anti-IgE. So we know that asthma is a type 1 hypersensitivity problem. So you have a lot of IgE and eosinophils, mediating those inflammatory reactions. This is a type 1, IgE mediated. So what do you want to do? Because we know the pathophysiology is that you have your antigen, binding to your IgE. Your IgE antigen complex migrates to the FCE receptor. That's just the receptor for IgE on the mast cells. So there are so many agents that have FCE receptor. One of them is the mast cells. You can find it in the basophil. So they go there, they bind to the Ig receptors on the mast cells, and when you have binding of two molecules of Ig, they can cross-link together. So cross-linking of those receptors brings about degranulation of the mast cells to release histamine, to release tryptase, to release, serotonin and other agent that drives that inflammatory process that they have. So why not just give something that can bind to that Ig and prevent it from coupling with the mast cell? So you can have this anti-IgE monoclonal therapy that can prevent binding, but I want you guys to know that this agent typically works on Ig that's still present within the circulation that have not bound to mast cells. Once you have binding to mast cell, forget about it, it can't work again. But what they do is that they go to the serum, they bind to the IgE there that have not bind, that have not bounded to, the mast cell. So any unbound IgE is being, taken care of by your anti-IgE monoclonal therapy so that it doesn't bind to mast cells and cause eventual degranulation of the mast cells. So that is that. So you want to use it in, allergic asthma with elevated IgE levels that is not responding to beta-2 agonists as well as the inhaled corticosteroids. So the methylxanthines, one drug that should come to your mind basically is theophylline. Theophylline is the commonest methylxanthine that we talk about. But before I mention anything, I must mention the fact that theophylline is cardiotoxic and neurotoxic. So you have to watch out with that. I think that's the concept that they commonly test with respect to theophylline. It is cardiotoxic or it can be neurotoxic. So it can cause seizures, it can cause irritability, it can cause agitation, it can cause dizziness because of the neurotoxicity. It has an excitatory effect on the CNS. And it is cardiotoxic because it stimulates heart contraction. So it can trigger some form of deadly arrhythmias, tachycardia, and all those things. So it has a narrow therapeutic index because you need very little dose of drug to trigger all this firing. So you must always monitor, an individual that you are placing on theophylline. It's a very, very sensitive drug. How does it work? It's a non-specific phosphodiesterase inhibitor. So just like sildenafil that inhibit phosphodiesterase 5, this guy can inhibit any of the phosphodiesterases. But it's been known to eventually cause increased level of CAMP. It can increase CGMP too, but majority of the time, the level of CAMP is actually more elevated. So it increases the level and prevents CAMP hydrolysis from the activity of the phosphodiesterase. That's how it works. So when your CMP is elevated, it can cause relaxation of the smooth muscles. And another thing that it does is to inhibit adenosine. So if you guys remember when we were talking about the antiarrhythmics, we talked about adenosine being a very good treatment option for somebody with a supraventricular tachycardia. Adenosine is a good option for them. And we're talking about some agent that can influence the action of adenosine. We mentioned caffeine, we mentioned theophylline. So theophylline can block all the receptors of adenosine. There are about three of them. Adenosine 1A, 2A, and 3A. It blocks everything. And adenosine is a drug that induces sleep. It kind of depresses the activity of the CNS, inducing sleep. It relaxes the cardiac smooth muscle, and it also constricts the brachial smooth muscle. So adenosine constricts the brachial smooth muscle. It relaxes the cardiac smooth muscle, the cardiac muscle rather. The cardiac, we don't have a smooth muscle in the cardiac, so we have a cardiac muscle. It relaxes the cardiac muscle. It contract the brachial smooth muscle, and it exerts sleep activity in the brain. It slows down the brain activity. So because of the fact that methylxanthines like theophylline blocks adenosine receptor, they can increase CNS activity. They can stimulate, contraction of the cardiac muscle, and they can really relax the brachial smooth muscle. So that relaxation component is what is bringing about the treatment option for asthma or COPD. But the constrictive effect or the contracting effect on the cardiac muscle is what is explaining the cardiotoxicity. And the stimulatory effect on the CNS is what is explaining the neurotoxicity. Don't forget it has narrow therapeutic index. Okay, so another one is the PDE4 inhibitors. So PDE4 inhibitors also like roflumilast. So they inhibit the phosphodiesterase 4, and that one is particularly involved in degrading the CMP. So that means that CMP accumulates, you can cause bronchodilation and also reduce airway inflammation. You can use it in COPD, to prevent exacerbation. Chromoline. So chromoline is part of under the class of the chromones. So chromoline sodium, what it does, or nedochromil, any one of them, you can see any one of them, nedochromil or chromoline. What they do is just to prevent mast cell degranulation. So you prevent, the mast cell from degranulating so that you can treat the asthma symptoms. So it's rarely used, rarely used. And the last there is anti-interleukin 5 monoclonal therapy. So this is not anti-IgE, but anti-interleukin 5. So it's one of the new modalities of treatment that produces an anti-monoclonal activity against interleukin 5. So interleukin 5 has been dedicated towards maturation, development, activation, differentiation of the eosinophils. It makes them very abundant. So it's like a growth factor that stimulates the existence of the eosinophils. And eosinophils is one of the cells that are predominant in people with asthma, along with the IgE. So if you give interleukin 5, you cannot have survival of your eosinophils again. You cannot activate them again. So there's no way they can participate in the inflammatory process. So there are two mechanism of using this guy. You can use it to, to to block the production of interleukin 5 directly, or you can, use it to block interleukin 5 receptor, just like the leukotriene antagonist. Are you blocking the leukotriene receptor by giving your montelukast or your ziluricast, or you are blocking the production of your interleukins, your leukotrienes by giving your Zileuton? So this is exactly what we are doing here. So if you give the mepolizumab or your risiluzumab, you are inhibiting the expression of your interleukin 5. So if you give your benralizumab, you are blocking the interleukin 5 receptor. So there's no way interleukin 5 can work, can activate anything, and initiate, eosinophilic survival. So this is just a chart that I've talked about everything we've talked about. So yeah, so that is that, guys. That is that. So do we have any question?
Mm, not for
Okay.
now.
Okay.
Well, sorry, I think I do, and it's related to the phosphodiesterase protein kinase C something. I don't know whether it's really what's it called here, but I really don't understand that concept, and I've been coming across it one way or the other. Protein kinase C, protein kinase A. Yeah, I don't know if you can relate it to this, because I mean we came across it with this to your feelings, so I don't know if you can relate it to
Okay. So
some.
protein kinase C. Protein kinase C is mediated through the calcium pathway. So anything that is activating protein kinase C will bring about contraction. So you understand when we start talking about pharmacology. Protein kinase C contraction. Protein kinase A can relax the smooth muscles, although its activity can actually vary, but majority of the protein kinase A is actually directed towards relaxation. Now let's go back to when we were talking about it. So we talked about protein kinase C when we were looking at the activity of endothelin. So this is it. Though this is not yet the time to talk about it, but let me just show you. So, Dr. Zulia, can you see this endothelin pathway?
Yeah, I can see it.
Yeah, so what happens is when you have conversion of this PIP2 to IP3, IP3 alongside with will cause release of calcium. PIP2 is converted to IP3 by phospholipase C. So this IP3 that accumulates, will cause release of calcium from the, reticulum. So when calcium, is being released, this calcium will now activate DAG, diacylglycerol. Diacylglycerol and IP3 are the product of degradation of PIP2. So when you degrade PIP2, you release IP3 and DAG. IP3 will release calcium, the calcium will move with the DAG, and they will all go to activate protein kinase C. Do you get it? Do you get it, Dr.
Okay.
Julia? Now,
Yeah.
protein
Yeah.
kinase C will now go and be phosphorylating all the proteins. That's what they do. So some of the proteins that phosphorylate to drive, contraction of the smooth muscle. That is it. Protein kinase C availability increases contraction of the smooth muscle. That is that.
Okay.
Alongside with the calcium. Alongside with the calcium. Then for the protein kinase A, if you are talking about protein kinase A, that means you are talking about the activity of CAMP. So what happens is that when you have um, um, any receptor, any agent that act on this CMP axis, when they act on their receptor, they are going to activate your GS. Let's say you are looking at the G protein coupled receptor, the S subunit. So when you activate the X subunit, it's going to cause um, activation of adenylate cyclase. So instead of phospholipase C now, it is adenylate cyclase. So when adenylate cyclase is produced, adenylate cyclase will help us recycle from the word cyclase. It recycles ATP to what? To CMP. So what would the CMP now do? CMP will go and activate protein kinase A. When protein kinase A is activated, there's relaxation of smooth muscle. That is it. So that's the
Right.
mechanism of
Yeah.
process
Thank
is
you.
happening. Hmm? Don't worry, when we get to pharmacology, we understand it more. So, do you have any other question?
No, that's all for now. Thank you.
All right. So, guys, I think we are going to call it a day. So everybody should go and rest. So, so what's our suggestion now?
Oh,